Hi, good evening, everybody. Welcome to another session of webinar. We were meant to have a session that is by Dr. Tay, and Dr. Tay is actually a hand and microsurgeon. But unfortunately, his mother-in-law passed away. So Dr. Tao has so kind to actually take over today's talk, and then Dr. Tay will give us the talk next week. At the end of it, we will actually have a QR code displayed to you guys. So just bear with us. And for those who cannot scan the QR code, before you actually scan the QR code, you must be watching through the computer and then scan it with your handphone. You can't watch it with your handphone and scan it, okay? So if you can't, then you have to, I'll tell you what to do at the end. So maybe without further ado, Dr. Tao.
Yeah. Okay.
Is it okay?
Yeah, okay. I will start now.
Yeah, you'll start now.
Hi, good evening, everyone. I'm Dr. To from Southern Medical Center. Thanks
Oh, you're
for
pronounced To, not Tao. So sorry.
So, no, it's okay, no problem. I think majority spelling is just how,
Oh,
Anyway,
yeah.
yeah. Okay. Thank you for those who are attending this webinar. Today I'm going to talk about the pregnancy guide. The guide. The topic basically is quite simple. I think most of you have been through in the ups and gynae posting, or even some has some years of experience in the ONG department, things like that. So I think today we just simply go through about what are the things that we usually need to focus on regarding the pregnancy, and things like that. Okay. Okay. I think I'm not sure about how many percentage of pregnant lady was actually being followed up in a private care, but I'm sure that it's quite a lot. Not only they are being followed up in the private obstetrician, but of course some are being followed up only in the GP. All right. So in the general physician. So of course, if the patient has come to you for any advice for whether am I fit to embark on pregnancy and things like that. I mean, of course, number one, whether the patient thinks she herself is ready to conceive. All right. So, I mean, from doctor point of view, of course, number one, physically. I mean, physically, more like whether she physically fit, and or more about whether she's medically fit. All right. So whether she's diabetic, hypertension, and things like that, obesity. I think as a doctor, then we can actually advise them, optimize the medical condition before they actually embark on the pregnancy. Mentally, emotionally, yes. Of course, lastly, financially, I think it depends. I think quite a big number of pregnant mother that is being followed in the private care. All right. So mostly, I would say 90 to 95% of the pregnancy, they are basically uneventful. So I think that there's quite a clear guide that how we should follow up in at each of the trimester, what should we do, and what are the advice for the patient, and what are the screening should be done for the pregnant mother. So I think for those who have attended a sort of like basic obstetric ultrasound, then that will be quite a good way to go about, so that you are more confident in terms of following up pregnant mother from beginning until their term. Okay. So just a bit of recap that when you say term pregnancy is from conception up to the birth. So basically it's up to 40 weeks. So we divide into 3 trimesters. First will be number 1 to 12 weeks. Second trimester is actually 13 to 27 weeks. Anything beyond 28 weeks is considered third trimester. So as according to the definition, term is actually between 38 to 40 weeks, but clinically practice we accept up to term by 37 weeks. After 40 weeks, it's considered as a postnatal pregnancy. 42 weeks is post-term pregnancy. I think in the practice now, it's either post-dated or post-date 1 week by 41 weeks. I think the practice now hardly we go beyond 40 plus 10 days, depends on the center, but I think mostly now they still induce by 41 weeks, especially in the government hospital. If any pregnancy is beyond like post-date like 40 weeks, then I think there's no issue if you decided to induce the pregnancy per se. As you know that if you allow post-date, then post-dated pregnancy, of course, risk of passing meconium is there and things like that, etc. All right. So I just going through few slides that at how many weeks that when a mother confirm they are pregnant, so based on the scan and what we should see. So I think ultrasound scan, I think the earliest that we can actually detected any sign of pregnancy, I guess, is at least by 4 weeks. So as time at 4 weeks, what based on the scan, what can we actually what can we see? So look at this picture here. You could actually see that there's a lining. This is the uterus outline. All right. So this is actually a TVS scan, a transvaginal scan. The bladder is anterior. So this is the uterus. So you will see nice round sac structure at the middle. So sometimes, when the bleeding scan that sometimes, people might label what is pseudocyst or what is pseudosac or what is true gestational sac. So if you focus on the slide over here, you can see actually the rim is slightly thicker than it's just a simple rim outside. So when you see a scan picture with quite a thick rim with a sac-like structure, so sometimes we describe it as a double ring sign. So when you say a double ring sign, that means that we are quite certain that this is the intrauterine pregnancy. Okay, so the earliest that we can see this is by 4 weeks. So
Sorry, can
I
I
mean,
stop you here for a while? But this
yeah,
is transvaginal scan.
yes.
Can we
This
see it through just an abdominal scan?
abdominal scan by 4 weeks unless the patient has very full bladder, number one. Secondly, if it's very anterior uterus, then you might able to see. All right. So I think I took a picture of this because I wanted to show them that what gestational sac looks like and what's the earliest time that you can see. I think it's not a hurry to say that by 4 weeks when you scan you see nothing, okay, come we go for TVS scan. That is not necessary unless the mother has some symptom like bleeding, pain, or things like that. When we have a concern about miscarriage or even pregnancy outside the uterus, then we might need to perform a transvaginal scan. But I think when you had that concern, I think if you're confident enough, if you're able, you are good, confident to do a TVS scan, then go ahead. Otherwise, I think should actually refer to obstetrician for them to reconfirm and to reassure that location of the pregnancy. So this by 4 weeks, that is what we can see. Slightly 1 week later, okay, then you would able to see these two structure. Number one, you were able to see a sac here. This is called a yolk sac. All right. This is actually the small fetal part behind. All right. So fetal part, in order to see, I mean the first, of course you can see the outline. The first structure that actually formed is the baby, the fetal heart. So in order to see the fetal heart, I think at least the size of the fetal pole, it should be at least 3 or 4 to 5 mm. Then you'll be able to see the pulsation structure when you're doing the scan. All right, so once you move on to 6 weeks, then usually 6 weeks, like I say, 6 weeks, you're definitely able to see a fetal heart. All right. So this is the picture that to show, but of course, this is a different patient. All right. This is the yolk sac that, yeah. One more thing is about, okay, when you see yolk sac inside the gestation sac, this we basically we can very sure that this is intrauterine pregnancy. So when you scan, you have been down whether it's inside, outside, pseudo sac or things like that. Whenever you see a yolk sac, then you're very sure this is intrauterine pregnancy. All right. So at 6 weeks, you should able to see a fetal pole and feel the short form. So this is the fetal pole. This is the fetal structure. All right. So the yolk sac will eventually become smaller and disappear later. All right. Okay, I think this why I've been through of all this, because as we know that a pregnancy, you have about 15% that they might end up as miscarriage. So a lot of time when you come, you are not able to, when you scan, uterus is empty and patient kind of bleeding, you're not sure whether is a miscarriage or still early pregnancy or pregnancy or unknown location and things like that. So you can go by the week, provided patient is very sure of her date, she regular period, and definitely she's not on any form of contraception or things like that. Then you can base it based on the date. But of course, you need doubt, then you can refer to us, or you by just doing a beta ECG. All right. So the beta ECG can give a guide is that, if the level is beyond 1000, you should able to see something like, SAC, York sac, even fetal echo. If we don't see that, then I think it's time that you should refer to a specialist to double confirm the scan. Okay. All right. So okay, basically just a quite straightforward, right, scan that to show you this, still baby inside this twin pregnancy, and then you see a lambda sign over here. So okay, sometimes you say, okay, doctor, we see two fetus inside. Okay, how should we go about it? So, we measure one and measure another one. So if this one, one is larger than another one. So which are the date actually we follow? Always we follow the largest one. All right. Of course, if the scan is quite corresponding to a patient estimated delivery date (EDD), then should be fine for that. All right. So um, just a very a very personal experience. I think quite recently, 2 to 3 months ago, I saw a patient at about 6 to 7 weeks. When I first scanned her, I only see a gestation, a single fetus, only one fetal pole. That's about 6 to 7 weeks. She came with very strong family history of twin pregnancy. Her uterus is very retroverted. She's otherwise well, no bleeding, all that. So I did a trans-abdomen scan. I see a singleton fetus, and I say, okay, at the moment, I think it's only one baby. So, and I could see a fetal heart, then, the dates all corresponding to her EDD. So I give her appointment 4 weeks to see her back. Surprisingly, after 4 weeks, when I scan, the first fetus that is about 7 weeks grow to become 11 weeks. And incidentally, I saw another fetus, which the size is about only 6 to 7 weeks. So basically, I couldn't explain why, at the first episode, I couldn't, see both, and only could see one. And the other one actually left behind. So I would actually generally do is that, if we are a bit down on the stand and we're not sure whether, especially when the uterus is very retroverted, it's really facing backward. So I think it's okay to ask for permission to perform a transvaginal scan. Of course, many mother might not feel comfortable just to do a transvaginal scan, especially when they are think that they're well and things like that. So I think this is something to share that, when in a certain condition or certain situation, then you might seriously want to look it more carefully. All right. So this is a picture of the 12 weeks. Okay, once baby reaches about 12 weeks, then you can see basically the head is well formed, the body, and you can see 4 limbs, and sometimes you see the umbilical cord is pulsating. So this is a very nice 12 weeks. And I think the picture I took here, not so, But Jeff, as we know that first timer scan, you sometimes can see the anti-scan, the knuckle translucency, then you can get the anti-thickness or that. But this picture I will couldn't show you. In the position the baby is all right, usually you could able to see all that, all right? And this is come out to 20 weeks. I think I had a slide about all the scan about this. Basically, this is the detailed scan. You know, we talked about when it's about 20 weeks, the detailed scan. So this is the fetal brain skull and the fetal brain structure, all right? So you can see a thalamus here, all right? You can see a short form and you see a CSP here. This is a lateral ventricle. This is the coronal plexus, and you don't see any cysts over here, all right? So cerebellum is supposed to be somewhere here, and this is external magna. So basically, this is how we look at the a detailed scan of the brain structure. Coming to the next, this is the sagittal view of the fetus. I think at this picture, I may need to show you this is the nasal bone. Okay, when you scan, you don't see a nasal bone, then we really suspect, you know, maybe could be a Down syndrome baby. So advice for the NICC or more further invasive tests to the mother. All right. So of course, this is another picture to show you that, you know, we can actually measure between the diameter of the both eye. So when it's widened, then it could be a sign of the syndromic baby. Followed by, this is the picture to show you that this is the nose with the two nostrils. This is the upper lip, and this is the lower lip. All right. So when you combine this picture and this picture, then you could able to tell the mother that actually, you know, the facial profile is quite normal actually. So it's not easy to look for the cleft lip and palate, you know. So I think sometimes might refer to the ultrasound scan or sometimes a fetal maintenance scan, you know, that we're able to see that much more clearly on that. All right, this is a picture that you to show about the baby heart, you know, the 4 chamber, and this is the intraventricular septum. There is no defect in between there. All right. So of course, I didn't actually put up other picture that you will see a 3 vessel view. Of course, the left outflow tract and also right outflow tract. Right, this is basically to assess the structure of the fetal heart is normal or not. Okay, this is a picture to show that okay, the fetal heart is here, and you can see the lung is over at the side. All right, that is the one single stomach bubble. All right, not very clear about the clear demarcation of the diaphragm, but you could able to see clearly. Let's say you don't see a stomach, then we generally will suspect diaphragmatic hernia, or you see 2 stomach, then you're concerned about duodenal atresia. All right, these are actually they might be associated with chromosomal abnormality. All right, so personally, I think detailed scan is very important for for all the pregnancy, and I think it's not very expensive to perform a detailed scan even outside. Right, so I think it ranges 100 to 200. So I think generally I would advise at all age of pregnant mother to go for detailed scan. As we know that NICC chromosomal testing is slightly more expensive, you know, between 1,500 to 2,000. So I think that is depend individually if they came to do for that. But I think most women, I will certainly advise for the detailed scan about 20 to 24 weeks. Okay, this is just show you the, you know, the finger with 5 digits. All right, and this is the picture that to show that, you know, a toe and 5 toes. I think it's all a proper detailed scan. They will actually look up for, you know, 10 fingers and also of course 10 toes. Yeah, so that to make sure that, you know, structurally on of course they look at long limb, you know, humerus, tifid, radial ulna, femur, and tifid as well. Okay, I think mother are more excited, you know, when they say, oh, doctor, do I have 3D, 4D scan, you know? So I think some they come to me and say, doctor, are you doing 3D, 4D scan? I'm just saying that I'm actually doing detailed scan, you know. 3D, 4D is just, you know, to form a, you know, so I think patient thought the 3D, 4D is the so-called the chunky scan. They thought they are the one who looking at the structure, but actually they are not, you know. All the detailed scan are being assessed by the 2D at the 2D view. Okay, so yeah, that's it. That's about.
Sorry,
Okay.
can I stop you here? What is 4D?
No, 3D is 3. When you say 3D, it's a single image. 4D is a video.
Oh, it's a video. I see.
Yeah.
Okay,
Okay.
okay.
This picture that I show you, this is actually we call 5D.
But
It's a
5D.
realistic scan. Yeah, so-called 5D. Yeah. So I mean, it's what the patient say. Oh, doctor, I have a 5D scan, all that. So I say yes, okay. Usually, what they do is they show the mother about a bit more realistic picture. Otherwise the true 3D 4D sometimes black and white only. Only the 5D you have a more realistic
So the 5D
approach.
picture is uh,
It's
a
the same. Is
three-dimensional
yeah,
video in color.
video in color. That's all.
Okay.
Yeah. So
See.
but I do not know, but actually they had 6D, 7D, some call VR scan, they mean they put on the VR and then they can see the 3D effect. Surprisingly, it really look nice, but of course the scanning is more expensive. Maybe I don't know, maybe close to 300. That is depends on the patient preference, but I think I always tell them what I advise you just for the detail scan. So I think most of the center actually they're doing detail scan. Commonly they actually invite the ultrasonographer to come over their clinic to perform the scan. So I think it takes about 30 minutes to 1 hour depending on the fetus position on it. Sometimes being the baby facing down, then it's a bit difficult to actually to assess the position, especially the face structure and things like that. Okay. Okay, who are at high risk pregnancy? So I would always group them on the top five. First, definitely would be like hypertensive disorder, any pre-existing hypertension, or any previous pregnancy induced hypertension, or any previous preeclampsia. All right, of course, diabetes mellitus, either they are type 2, either type 1 or type 2 diabetes mellitus, or they are previous otherwise previous gestation diabetes is quite all right. Not to say they are actually at high risk. This is referring to pre-existing diabetes mellitus. Of course, chronic kidney disease, as well as autoimmune disorders such as APS, SLE, and etc. Okay, as we most common practice that if the mother having these five either one condition, usually will start low dose aspirin for them after beginning of second trimester or end of first trimester. All right, so recommended dose is the 75 mg, but sometimes now they're given up to 150 mg OD. All right. Okay, certainly HIV infection is important. So I think booking is very important. Make sure they are on hand, and then by elective C-section or by breastfeeding, then you can actually reduce the vertical transmission. All right. Yes, cancer, of course, they are immune compromised. Any pregnancy, if age they are above 40, all right, or teenage pregnancy less than 80, BMI more than 35 or BMI less than 80. All right, of course, smoking, alcoholic, and of course multiple pregnancy, they are all high risk pregnancy. So as you follow up a multiple pregnancy, yeah, of course, first of all, we say, yeah, congrats, got twin, yeah, but of course, a lot to come, when it comes from the counseling, especially from the beginning, as multiple pregnancy, all the risk of the pregnancy almost double, high risk of miscarriage, preterm bleeding, abnormality, preterm labor, and things like that. Okay. Okay, quite a general advice for all the pregnancy taking folic acid, aim, optimize the BMI, stop, alcohol, and smoking, very good lifestyle. Any medical condition, optimize it and oversee their doctors. I think most of the, I would say, the primary care are the one who actually see most of them pre-pregnancy. So I think it depends, if they are coming for advice, I think this is what you can tell. But most of them actually, your normal patient, your regular patient, suddenly they come on the plan pregnant. So doesn't matter, even is still an early pregnancy. I think this is still a very good general advice to tell them so that they would able to adhere and to follow it. All right. So as first trimester, Usually their anxiety, especially finding a lot of questions to ask, they were having a pregnant symptom. Like I said just now, risk of miscarriage is about 10 to 15 percent. Okay, organogenesis is actually completed by first 6 weeks. That means the period is already 4 weeks. By the time 2 weeks, so I would say this is actually the crucial time for them. So it's very important sometimes when we see, okay, is this a planned pregnancy or this is not a planned pregnancy? But it's a planned pregnancy, patients are more aware that, they are in the, in the process and, in getting pregnant, if they miss a period, you've done a UPT at home and, when they're positive, then they're able to know they come forward, they will avoid this, they need cautious on their food, on their drinks and things like that, and they will make sure they're taking the policy. So for those unplanned pregnancy, a bit difficult to say. So this is why we always advise that if during the first trimester, maybe we try to avoid any travel and things like that. All right. So I think first trimester is time for the booking. All right. So advise them on diet. Patient always they always ask, doctor, when is the best time to scan actually? I think between 6 to 7 weeks to scan is okay. All right, no problem, because 4 weeks, 5 weeks, you sometimes won't be able to see anything. Of course, 8 weeks, not to say too late, you know. Yeah, of course, at the background rates of atopic pregnancy about 1%, in a general population, if let's say usually it rupture between 6 to 8 weeks. So I would say if the patient has no symptom and things I think if I want to scan between 6 to 8 weeks, I think that should be fine. No problem. All right. So
Sorry, Joe, can you go back to 2 slides
yeah,
before this? Okay, I want to
this
ask
one.
you, no, then, okay, this folic acid. So this
Yeah.
folic acid, do you advise patients who are planning for pregnancy to take folic acid before they get pregnant?
Yes, definitely. Actually, yeah, sorry, I should make a comment on that. Actually, folic acid is supposed to be taken 3 months prior you plan for pregnancy. All right. So generally, yeah,
Uh-huh.
3 months prior to that. Okay, because why 3 months? I think to replace the folate deficiency, it's not that you're taking 1 week, 2 weeks, and 3 weeks. It takes about 3 months. So general advice, you advise them to take 3 months prior to that. The general preparation of folic acid in the market usually is 5 mg, but minimum requirement is 0.8 mg. So I do see some of the patient, they get a preparation of 400 microgram. Yeah, in the packaging, so that you advise them to take two. If they have bought a 5 mg one, it's okay, no problem. Either 0.8 mg or taking 5 mg has no problem for that. All right.
And can I
So
know what's the benefit of this folic acid other than maybe for anemia following pregnancy? Is there any other benefits?
yeah, certainly. Okay, I mean, if when we're referring to the hematinic needs, the main three components that we are asking the mother to take, number one is folic acid, followed by vitamin B12, as well as the iron. Iron, that is for
Yeah, that's right.
reproduction of the red blood cell and things. Folic acid is very significant when it involves the neurotic defect. So you, as a population, if you take folic acid, actually reduce 50% of getting anencephaly or some type of neurotic defect.
Oh, I
So but
see.
yeah, but even you say 50%, but you look at the background, is for a general population, those who without taking folic acid, 2 out of 1,000 they might end up with neurotic defect. But by taking folic acid, out of 1,000, maybe you get one. So from 2 in 1,000 reduced to 1 in 1,000. This is how it come out about 50% reduction. I mean, looking at the number to say is not very much significantly, but when you compare out the 2 in 1,000 to 1 in 1,000, yeah, obviously there's a 50% reduction.
And it's such a simple drug to use.
Yes,
Very readily available, and
yeah.
actually it is a lot of reduction if you say it's 50%.
Yes. I mean by statistically, definitely, because it
Yes.
reduced 50%. So generally for those who are planned pregnancy, I think this is the one that usually they will start taking, or they sick, come to their doctors to, oh, doctor, I'm planning for pregnancy. What do you think? What should I do? And things like that. This is a general wife taking policy, and things like that. All right. So pregnancy symptom,
Okay.
the morning sickness, craving food, or tired, urination, breast engorgement, and things like that. All right. So okay, this is something just a bit add on about organogenesis completed by 6 weeks. So this is a crucial time. So if I think in the general practice, in a woman who want to, you subject them for X-ray, then you always ask them for the MMP. All right. If you surely have any doubt or anyone had a PO, a period of amenorrhea more than 4 weeks, I think prefer to be, maybe done a UPT and things like this. Make sure
Sorry,
that
I can't hear you very well. Maybe if you speak
yeah.
louder.
Okay.
Yeah.
Is it okay now? I
Yeah, it's
think
better now.
yeah. Okay. All right. So like I say, it's crucial time to avoid anything during these 6 weeks or up to 12 weeks. So very important that, when any women actually, any reproductive age women, if they're subject for an X-ray, the first of all, always ask them, when's the MP, make sure they are not pregnant, things like that. Just do a simple UPT will do. If UPT is negative, is indicated, then just go ahead for the sex X-ray. Ultrasound is very safe because it's a sound wave. If I have a lot of couple asking, oh, doctor, do you think I can travel or not? So my general advice still that try not to travel. All right.
Oh, why?
No. You can travel. I'm not saying that you cannot travel, but for those who has planned the travel, I say then just go ahead. If they just say, doctor, can I go? I say, but you preferably no
Oh,
lah.
that's a bit.
Especially. Oh no, sorry. When I meant travel here, is like airplane. You going on a long trip or things like that. It's a air travel rather than to not a normal.
Okay,
Yeah.
this travel that you are saying that we should not travel, is it because of does travel really increase the risk of miscarriage?
Not really. Not really. Yeah. It's just that, a lot of uncertainty, especially during the first trimester, you might have bleeding, you're going overseas, and, a bit of kind of hassle, things like that. But
Inconvenient.
not to, that's why you say avoid, but not to say no. Yeah, if possible.
Okay,
Yeah.
because it's very important. I don't want people to think that, by
Yeah.
being pregnant, you travel, you increase your risk. So it
Yeah. Yeah.
doesn't. It doesn't.
Yeah,
It's
it doesn't.
like
Yeah.
an
Yeah, of course, you said
inconvenience.
you travel to the different level of the sky, the radiation and things like that,
I
but
mean,
it's
if
not
you
proven.
bungee jump, I can understand now.
Yeah. Yeah. The other thing you said to travel as the air travel, because let's say you travel 4 to 6 hours, you actually increase your risk on a venous thromboembolism.
Yes, that's true. That's true.
Yeah, I think it's based on a lot of this and all that. If you're asking me, you're just about to plan to travel, then I say probably just no lah. After that,
I see.
also any teratogenic medication, morphine or things like that, then they should stop and to seek their doctor as soon as possible. Definitely stop alcohol and smoking and things like that. So, okay, first trimester is very important. It's the booking. When you say bookings, the first time you meet the doctor, we perform a scan, like the things that I showed earlier on. Basically, all the visit we check on blood pressure, we check the weight. Of course, the urine we always check for any protein or any sugar. Basic viral screening as well as the blood group and hemoglobin, all that. So we always do a very general medical examination just to make sure that the mother is okay, there's no heart problem or any lung problem and things like that. Right. Basically healthy diet, like I would say, more fruits, vegetables and fibers, drink a lot of water. You can do exercise, but just avoid rigorous. Try to avoid caffeine, illegal drugs, and all the seafood, raw food, raw vegetables, and things like that. For those who are having a cat as a pet, all that, then I think should watch out about their litter and all that, because that could carry a higher risk of toxoplasmosis infection and things like that. All right. So, okay, come up to 13, 20 weeks, the start, the uterus is growing out from the pelvis. So their, uterus is start appear, in the tummy. So, of course, baby will grow much faster, belly has become bigger. Okay, once they go beyond the first trimester, they're getting away from all the pregnancy symptom, all that, they're actually getting better, easier compared to the first trimester. All right, so sometimes, pregnant mother, they come, doctor, I be a dizzy, lightheadedness, and, sometimes I think that because peripheral vasodilatation that is slightly lower than blood pressure. So this is quite a common one. But again, like I said, during the first trimester, we examine her heart and things like that, make sure that nothing wrong with things, about her cardiovascular system, lung system, and things like that.
Okay, so
I
this
think
lightheadedness and dizziness is really is not due to the hormonal changes, it's due to the blood pressure lowering.
no, that could be one of the reason. That could be one of the reason.
Okay.
Hormonal changes that does not actually cause um okay, like we say, when women, they're having about to having their period, things like that, they might have DC or that because of progesterone effect. Cause the pregnancy, estrogen will be high, progesterone will be high, and things like that. And most of the pregnant mother, when during second trimester, when you scan, you check the blood pressure, probably about 100 or 60, 90 over 60. They come to you, doctor, I be a dizzy, but otherwise they are well. So what I think is that you need to reassure them, yeah. So just to make sure that they are actually, they are well, they have no problem about that. All right. So there'll be slight dropping, the HP, that is quite common due to hemodilution for them. Symptom, okay, yes, quickening, they will start to be felt. Primary usually about 5 months to 6 months, 20 weeks and above. Multi usually about 16 weeks onwards, they were able to feel that. So first pregnancy they cannot eat. Now first trimester they can't eat. Second trimester their appetite will become better. All right. So the anger and the hand will start swollen, and stretch mark start to appear maybe late or second trimester. All right. Skin itchiness depending, because as uh, your belly is getting bigger, and you start forming a stretch mark, or that, then they might have a skin itchiness over there. Okay, during the second trimester, of course, a routine fetal growth. Of course, we do a diabetic screening. We follow our national guideline. 25 years old and above, we will do a GTT for them. If they are significant history like diabetic, previous GDM, BMI more than 30, yeah, age more than 35, then they should have a early diabetic screening and things like that. If that's normal, then maybe early of third trimester, you can perform a repeat screening for them. So this is the test that I mentioned just now, NSCC and NIPT. It's non-invasive genetic testing. All right. So basically, you just draw a blood, and a very simple procedure, but that you can able to screen, because even though you say it's screening test, but the sensitivity is very high. So
So this
usually
non-invasive genetic screening test, the NICC, what does it screen for? What kind of disease?
basically is screen for any trisomy, common 21,
Okay,
Down
so
syndrome
Down
18,
syndrome.
Everett, Patel 13, sometimes 6, 9, or even 16. Of
I
course, they
see.
also they'll screen for sex chromosome abnormality, 45XO, for 47 XXX, 47 XYY, or things like that. Of course, sometimes they also screen for those mild a synonym, maybe like Prader-Willi and things like that. So I think
Okay, so this NICC, when it screens, is it a standard test?
no, it's not a standard,
So
it's
you
the
have to
optional one.
pick what you want to screen for.
No, it's the screening is standard. Screening is standard,
Standard,
but
it
it's
will come
not.
up with a
Yes,
whole list of things.
yes, but this is not applied to all the pregnant mother. But particularly, I would advise for anyone who age more than 40. As we know, age 40, 1% on Down syndrome baby.
Okay. And where
All
do
right.
you send this screening to?
I think if in Sunway we have we outsource actually, there's a DNA lab, Panorama lab, Gribble lab, and
Okay. And how
some
much is
other.
it on a
Yeah,
general?
between 1008 to 2002 between them.
And you can also do this genetic screening through your other method, right? Sorry, I never done.
No. This is okay. When we say this, when it's non-invasive, you basically draw a mother's blood about 10 cc. Then you filter all the cell-free fetal DNA.
Okay.
So I would say they are quite accurate because at the moment, I'm not see a NICC normal eventually end up with a normal baby.
Okay.
Okay, but we did detect abnormal screening report result, but actually pregnancy is normal. Like, mother just had a miscarriage 3 months ago. They might still having some random fetal DNA from the previous, miscarriage. So they might able to pick up from there. So if let's say NICC show abnormal result, then the next thing you have to do is the amniocentesis from there. Detailed scan, like I explained just now, what we are actually looking through for all that. All right. So this is the picture, the summary of what I showed just now. Okay, when we come to 28 to 40 weeks, this is what we meant for third trimester. All right. I think at this time, so physically more challenging is because their tummy is getting more and more bigger, and a lot of patients that come uneasy. A common question I get from them, I ask doctor, should I sleep supine, should I sleep the side way, left side, right side, and things like that. So I think there's no rules for that. I always tell them, you can sleep on left side better, right side doesn't matter. If you can't, then just sleep like any position you like. All right. So certainly kicking is more more obvious compare second trimester. Sometimes they get irregular contraction. Some they don't actually feel anything, but some even at 26 weeks they tell you, doctor, actually from 26 weeks on and 24 weeks, I start feeling the contraction. Sometimes even I feel the pain. When you feel the pain, it means that the intensity is quite significant. But as long as it's not regular, I think that is fine. I think because of gravid uterus, then they will urinate more regularly. Okay, then they're having a bit more the heartburn sensation more. Generalized swelling. Okay, more generalized swelling. I think here I refer to a fetal edema. So in the normal pregnancy changes or that, I expect fetal edema. I mean angle swelling. Actually, after 32 up to 36, if you have an angle swelling much more earlier, like 20 plus week, I think make sure they monitor her blood pressure, as well as the urine protein, make sure that she's not hypertension in pregnancy or she's not preeclampsia. All right. Yeah, of course, hemorrhoid can be common, and because of gravid uterus, they will have sleep problem. Um, okay. At third trimester, I think it's very important. As we all know that at 28 weeks, maybe about 1 kilo. I think this is quite a good terms to follow. 28 weeks onward, every week baby grow about 200 grams. From there, actually you can count it. 28 weeks, 1 kilo. 30 weeks about 1.4. As time go that you count to 36, 38 weeks, probably baby about 2.8 to 3.2 kilo. So that you can actually sort of knowing that the proper weight gain for the fetus. All right. So of course you need to estimate the fetal weight at term. Of course you will assess the position, presentation, and LICWA, volume, placenta localization, in order to decide in the mood of delivery at the trimester. Usually I discuss the mother after 30 weeks. At least they'll know what's the plan for them. But this is the picture to show this is a giant baby. All right, so this is probably about 5 kilo baby. All right, so also very important to get them ready for labor. As now we can't attend any antenatal class, I'm sure quite a lot of private obstetrician in the private center, or actually they conduct a lot of antenatal class. All right, basically it's just taking through them from beginning of the pregnancies, mid-pregnancy towards the late pregnancy, what they expect throughout. Okay, and then of course, very important, I think we should start educate our mother about breastfeeding before she gave birth actually, you know. So generally just get them prepare the so-called delivery bag and things like that, so the item they need when during or when they're in labor. Okay, so getting ready or labor, so we at about come to 34 36 week we will develop a birth plan with them. You know, first of all, it's based on assessment, make sure that you know she fit for whether she can go for vaginal delivery or she need for go for C-section, you know. Of course, if a patient who are going for vaginal delivery, I think it's very important to discuss with them about anesthesia and labor. All right, so we have companion breathing exercise, we have ethanols, we have opioid. Of course, most definitely more significant is epidural. All right, so I think most of the private center they were able to offer epidural to them, so I think that is fine. Okay, so support and labor usually husband or the partner to be around during the labor and things like that. I will generally do a GBS screening, all right? So at especially 36 or later by 37 weeks, you know, just a gentle swab in the lower vagina, make sure that she's not a GBS carrier, all right? So even as I mean, in our national guideline, there's no to say that you must do GBS screening, but I think my practice usually at 36, I would advise for them the GPS and recover intrapartum antibiotics for them. Labor symptom, okay, you can advise them this is the common labor symptom. Okay, and then we'll tell them when she in labor, and then it will take about 48 hours, it can up to 12 hours. Okay, and you know, as it's a painful event, and then you know, depends on threshold as well. So I think the three common things is very important in labor. So adequate hydration, and then you know, adequate pain relief. All right, so that you will avoid the exhaustion before they reaching the second stage of labor. If the progress does not go so well, you know, artificial rupture of membrane or actually, sorry.
Never mind. Go on, go on.
Yeah. Artificial rupture of membrane or oxytocin infection. Yeah, that can actually shorten the duration of labor. All right. So I think this three stages. First stage. Okay. Now we used to say early labor is 1 to 3 cm, but now actually revised to 4 cm. So that means when you reach 4 cm, you consider active labor. Why we divide latent or active? When we say active labor, that means there's a standard rules to say that you know when you reach active labor, the cervical dilatation will be 1 hour 1 cm. So from there you have some sort of expect that you know at one point of time the, the mother should have delivered by then. All right. So second stage is when she's fully okay. Second stage you by guideline actually you can give up to 1 to 4 hours. 4 hours is primate with epidural. So usually we give maybe about you know 1 hour and things like that. Of course, you might need any assisting delivery, especially in the event that you know prolonged second stage or you know poor maternal effort or any like you know, heart disease, especially they try to shorten the second stage or any fetal distress as well. All right. So this is the mechanism of labor and delivery of placenta third stage. Usually complete by 40 minutes or by within an hour, right? Usually placenta if is meant to be delivered usually by 20 minutes of third stage, they should have actually separated well and you're able to deliver the placenta. All right. So our common practice will, you know, for those who avoid a PPH, we'll start active third state management, you know, clamping and then gentle pulling and give a urotonic injection for them. All right. So okay, I think come out to postpartum, of course, you know, baby are delivered and things like that. I think this is the postpartum, the 6 weeks is a very crucial time that you know for the mother to recover to what they are what they were before their pregnancy, you know, a good rest, of course good food in a confinement center, things like that by the confinement lady, and of course the important of breastfeeding and things like that. Okay, So yeah, there's something, postpartum with baby and all that, working mother and things like that. I think what I want to stress about is this is actually is postpartum blue or depression. I think this is I think many people, or no, sorry, many women, they didn't actually come up with, to say I actually have the symptom and things like that. But I believe that so many of them, especially after you see them, after 1 week or 2 weeks, especially primate, when at home they are alone, husband is working, only them with the baby. When you are not able to handle the baby so well, that is time, they are more vulnerable to go into postpartum blue. Of course, words is depression. I actually, once a while I get a call from the patient. They will say, doctor, actually I having all this the symptom and things like that. That mostly are they are left alone and things like that. So I think they should come forward, and you should refer them, give a counseling, and give the support that you can. All right. So yeah. So I think this is a bit out the topic, all that. So I think now since May 25th, I think we start giving COVID-19 vaccine to all the pregnant mother. I think Sunrise Pyramid Vaccine Center, I think 2 weeks ago, we just started to have the first batch of pregnant mother for COVID-19 vaccine. Then that day we give almost 1,007 pregnant mother. So most of them, they all went well and things like that. So I think there's a bit of confusion before this. I think, the website said that in fact, AstraZeneca or the Sinovac vaccine are also safe for pregnancy. I think eventually they brought up the issue. I think they take down the update. So at the moment for pregnancy, I think it's only Pfizer vaccine. All right. Of course, the advice is between 14 to 34 weeks. But anyone they come 34, 35, 36, I think it's okay to go ahead with that. Even if so, unfortunately, if they deliver for during the second dose, I think it's fine. I think it's fine for them. They can delay until the deliver, and up to like 3 weeks or things like that. So I think as well within 1 to 2 months, up to 3 months to complete the second dose, that will do. All right. So certainly all the COVID vaccine, I think the 3 vaccine, I think the fourth and the fifth, I'm not seen one. I think at the moment with Pfizer, all right, I think I heard Biotech's coming, but I'm not sure. I'm not sure when. AstraZeneca and Sinovac. So for breastfeeding, yes. For Pfizer, there's certainly no an issue. AstraZeneca is also all right. Sinovac, just they do not produce much data on all that. So I think that is after the counseling, the doctors all that, and then and then to make a decision whether they want to get a Sinovac vaccine or not. So I think I generally advise pregnant mother to go ahead with COVID-19 vaccine during pregnancy. All right. So just avoid the first trimester will do. All right. Of course, they are postpartum. You just go all out for any of the vaccine will do. Sinovac, yeah, maybe just keep with you on that. I think this is just a summary on all that. And I think, yeah.
Okay, we
Yeah.
have a few questions.
Yes, can. I think
Already.
I can bring down.
Are you maybe you stop sharing your slides so that
Yeah, can. Sure, stop.
then
Mm.
I will put up my slide on the QR
Yes.
code so that while we answer the question, they can scan the QR code. Okay, so
Yeah.
while I'm doing, I will, while you're
Can I see where I can actually see the question actually if or no, if I can see the
yeah,
question.
you can see
I,
the questions.
yeah,
I need you to
where,
switch off your sharing.
okay.
Okay. So Tan Joni asks, what about certain food that may increase the risk of miscarriage, such as pineapple? Tan Joni, are you a medical person? Are you really a medical person to ask such a question? Okay. Okay, so maybe you can answer that. Is it a myth or is it a fact?
Yeah.
Maybe you can take away your slides first.
Yeah. Okay.
Stop sharing your slides.
Yeah. It's how to off this. Okay. Yeah. Okay. I off the share.
Okay, thanks.
Yeah. Okay.
Okay, so this is okay. So that is good. So you all can now try to what? So is it a myth or a fact that a pineapple can cause miscarriages? Dr. To?
Oh, I have no answer for that actually. But
No
I think
answer?
no. I don't know. But what I know is many um female, they believe that by taking a pineapple they can actually
But as a
to have
doctor, what
this.
is your belief? What do you think would
I
be?
I can't say because there's no scientific a study and things like that to say that pineapple will cause miscarriage. So I got
Okay,
no answer for that. Yeah.
okay, okay. So to Tan Joni, I don't believe it does. Okay, I don't believe it does, and I think it's a myth. Okay,
Yes.
Chiu Ming asks, can airport
Oh, I
scan
think the chat
affect
here. Yeah.
early pregnancy? Okay.
Sorry.
Uh,
I can see the question now.
yeah, can airport scan
Okay.
affect early pregnancy?
Uh, I'm not sure because I'm not sure what kind of the method is. Usually what I know is that they're using the heat rather than radiation. So I
Okay.
not sure about
I
that.
don't think airport
Yeah.
scan can affect early pregnancy or any pregnancy. If
Mm.
not, there will be a
Then
protocol or a guideline for for pregnant women in all airports. I think not. So avoid ultrasound scan in early pregnancy, but ultrasound scan is safe.
no, okay. Referring to this, ultrasound definitely is safe in pregnancy. Of course, this is big tips that to say that if maybe if sometimes when you scan you want to show them a fetal heart all that, we use a bit of like fetal Doppler. Of course when you use a fetal Doppler mode, maybe there's slight increase in the heat of the sound wave, but that actually not significant. So in a general way to say that ultrasound is very safe in any of the gestation, no problem for that. All right.
Okay.
What antiemetic is safe in early pregnancy? Okay. Usually in early pregnancy, the common one you use actually meant for the pregnancy, usually the Veloxin. All right. So or sometimes even the Maxolon you also can give. Most of the antiemetic are safe in pregnancy. There's no issue for that. Of course, I mean in a very severe hyperemesis and things like that, sometimes we will use prednisolone or hydrocot, but that is at the hospital level, not at the general practice. So I think it's okay for most of the antiemetic for pregnancy. How long? Yes, depends on their symptom. I have given patient a Veloxin, they'll be taking for the 2 weeks duration, all that. So as long you are okay to take, they're no allergic, then should be fine. Usually hyperemesis symptom it lasts 1 to 2 weeks. By the time of then they was getting better. The peak of hyperem is usually 6 to 8 weeks. By 10 weeks is the symptoms should have tapered down quite better. All right. Would it be effective to do NICC after 20? Yes, anytime can do NICC, doesn't matter. All right. Any
If
indication?
you do an NICC after 27 weeks or even before after 16 weeks and it comes back abnormal, what can we terminate the pregnancy?
Okay, if let's say Down syndrome per se, Down syndrome is not a little congenital malformation. So if we follow our national guideline, Down syndrome is not for TOP, termination of pregnancy, unless it's Patau, Evert, or some other rare little congenital malformation. Yes, that we can terminate the pregnancy. Okay, the other thing is that why we like we say, okay, if let's say NICC, we do not advise to do much later in pregnancy because we are aimed to detect any abnormality. So it should we have done much earlier, but not too early. NICC, the earliest you can do is 10 weeks actually. Usually I do up after 12 weeks or about 12 to 13 weeks, you know. Sometimes they 11 weeks suddenly they end up miscarriage and things like that. So I don't do at 10 weeks, but the earliest you can do is 10 weeks actually. So any indication for NICC below 40? Yes. Any previous abnormal baby, any family history of abnormal baby, and um, anyone, if in the form, there's a, they will ask whether, abnormal screening, like, sometimes do a first trimester scan, a combined test, it show high risk, then you will do NICC, or even the triple test when it show abnormal between 15 to 20 weeks, then you might advise for NICC test. Of course, maternal age is one of indication. Of course, maternal request is most of the indication because they want to know. Yeah, so yes, below 40, like what, like I say,
Hold on,
if
can I
possible.
stop you here first? Okay, I'm so sorry. Is the QR code only half shown? Can you all scan? Anyone having problems scanning with a QR code? Okay, if you're watching the webinar by phone, you cannot scan the QR code. Okay. If you have problem scanning the QR code, you need to actually message me, okay, and give me your name, IC, MMC number, and your email, and then we will manually do it for you. So sorry, yeah. Okay, yeah, sorry.
Okay, now I just going through the question. How do you deal with bridge presentation? Okay, bridge presentation by 36 weeks, about 4%. So actually it's quite straightforward. I mean, bridge presentation, the mode of delivery is by elective C-section, all right? So as the term bridge trial is say that, is actually basically reduce perinatal morbidity and mortality if the mother is subject to elective C-section, all right? So in a private practice, rarely anyone they try to do ECV, external capillary motion, but in the government they do, they does, all right? So no, not to say yes or no, but generally I think bridge, there's two options: either you elective C-section or you attempt ECV so that she can aim for vaginal delivery. Sex during pregnancy, yes. When to stop? No. Actually, it's allowed for sex in pregnancy unless she had any bleeding, any previous history of preterm labor, cervical incompetency, placenta low-lying, placenta previa, and any cervical causes and any abnormal bleeding in pregnancy, any infection and things like that, that we will say you no sex in pregnancy. Otherwise, I think it's okay for that. All right. So I always tell the couple a gentle sexual intercourse. So they were laughing, what do you mean gentle sexual intercourse? Yeah, but it's allowed, during pregnancy. Okay.
Okay.
Yeah.
In your list of patients with high risk, I think you didn't mention cardiac problem like Eisenmenger.
Okay. I think the reason that this is certainly, of course, we're talking about, I mean, congenital cardiac heart disease or any acquired. All right. So um, maybe in this topic we don't go into heart disease in pregnancy. Then we can actually, but what we usually, if let's say they are having congenital heart disease, they we already pre-know of that. So there'll be, from the care, the follow-up will be, a combined care between the cardiologist as well as the obstetrician. So I would say the pregnancy being well taken care of. The only thing that we wanted to pick up is any like, uh, uh, peripartum cardiomyopathy. A lot of pregnancy symptoms, they actually, they are, as the pregnancy get advanced, they get a bit breathless, they reduce effort tolerance and they cannot lie fat and things like that. So this, you know, a very common symptom that might actually mimic the heart failure symptom. So I think it's very important time to time to, to assess the pregnant mother. Then, so what I used to, the common practice where, how are you doing? You coping well, if they raise any concern like, doctor, my ankles get swollen, a bit breathless, now I need to sleep with two pillow. I think very important, the clinical assessment, all that, try to, pick up any murmur, any like, lungs, any crepitation, any some severe heart failure and things like that. That will start to give us some clue. Of course, you're talking about heart disease in pregnancy, of course, there will be, which are the one not fit to carry on the pregnancy, all that. So maybe we can arrange another topics about, heart disease in pregnancy. Then probably Dr. Betty can give us even a better
Okay. The
better
reason,
talk on
yeah.
it. Yeah.
The reason why I brought this up is because you had a slide that showed what was what are all the high risk pregnancy
Okay.
and then what to look out for, and you didn't mention any heart disease for that matter.
Yeah.
Either Eisenmenger, which is actually right to left shunt, or any other heart problem. And the reason why I mentioned this was because when I was in University Hospital as a lecturer, actually there was this lady who delivered. So she had no no problems during her delivery. But when we look at the notes, her heart rate was running about 130 to 150 throughout the later part of her pregnancy.
Okay.
And immediately after she delivered, she collapsed. And what she had was she had atrial fibrillation that nobody actually picked up. Okay. And she actually has severe mitral stenosis and severe aortic stenosis. So post delivery, I was basically doing CPR on her while my boss was trying to do mitral valve, okay, valvuloplasty, okay. But after that, she survived that, but we couldn't tackle her aortic stenosis because at that point of time, there was still no percutaneous method. And she eventually died following that. Something that could have been prevented before she got pregnant, something that she could have picked up, and something that we could have treated, maybe lower the heart rate so that her heart could cope better, Yeah. So it was a very sad case for me.
Yeah. I think a bit of add-on is that, in the OSC, actually for all the heart disease teenage girl, they actually will arrange a session with them when they're about 13 or 14 years old. All right. So there'll be assessment of their heart condition and there'll be a session for them about the contraception. All right. Of course, I think contraception it's a bit technically a bit of a issue that to electively to give a contraceptive talk to our younger generation. I mean, younger age population in Malaysia here. So, and also what they're doing is that some other, especially in the UK, they would have a sort of like a screening program, you know, for all the teenage girl about, you know, a general screening about the heart checking and things like that. Hopefully by then they could able to pick up any like abnormality, and then, you know, they would able to, you know, to pick up her problem much more earlier. And most of the cardiac failure patient, you know, based on my experience, they it's not easily to detect during antenatal or during intrapartum, because most of the mother when they're in labor, they're all breathless because they're trying to, you know, push and things like that. A lot of time is after the delivery, you know, within the 24 hours up to the 5 days. Most of our peripartum cardiomyopathy patients are being detected, especially due after the postpartum period. Like, you know, commonly they'll be breathless, then they'll be tachycardic and things like that. Yeah. So
Okay, so
yeah.
postpartum depression, of course, I think we treat like all depression, right?
Yeah. Yes. Yes.
Yes, so we treat like any depression, we use
Yeah.
SSRI.
Yeah.
Okay, so I think we will stop here.
Yeah.
Thank you very much for Dr. To for
Thank
coming
you.
in such a
Okay.
short notice.
Yeah.
And I will see you when I
Yeah.
see you in
Again.
Sunway.
Yeah.
Okay, I see you guys. Okay, so
Okay.
next
Thank you very
week,
much.
please do come in. Dr. Tay will come in and give us the talk on common hand diseases. And it will also give one CPD point courtesy of Sunway Medical Center. And have a good week ahead and stay safe. Bye, To. Bye,
Bye.
everyone.
Bye.